communities. So I think one of our jobs right now is to actually step up and say, hey, here's how it's working really well over here, or here's how parts of it, the attributes A, B, and C are working well, so that the bigger system can learn from that. So I think we have that huge obligation. And even more than that obligation, I think if we don't step up and actually speak and share about what works well in our small rural communities, then this patient medical home model will just roll out. And the bigger system will be telling us how it's supposed to be. And worse, it will break what we do well already in our communities, right? So I think we have this huge obligation to join with this in whatever way we can, whatever stage we're at, to speak up for what's working well, and for what the real enablers and the real new pieces that we need are. So I, as a rural community doc, don't need to learn about the benefits of team-based care. I need you to help me with writing the MOU and getting the details of how to get that nurse working well in my practice, right? I don't need to be sold on some of the principles. We're already there, we're at the next level. So this is the model we were handed. GPSC model. I think about 1.5 years ago it used to have draft across it. Somewhere along the way it stopped having draft. Now it seems to be the model. It's quite similar to the model they're developing in Ontario, so that, you know, I think it's a good model. I think there's some things from a rural perspective right off the bat that don't quite fit. My 2 thoughts about that is, I think it needs to be patient medical homes, right? Because it's gonna be different in each community. That's true urban versus semi-urban versus rural versus remote. It's gonna be different in each place. If you buy a bungalow today and I buy the identical bungalow, 3 months from now when we look at those homes, how we've settled in, they're gonna be completely different, right? Where do you put the tea and coffee in your house? It's different. And so each of our homes, in terms of patient medical home, is gonna be really different. So please let no one think we should be developing a model. We need to have, as they've described, the attributes, the principles, but then how it plays out in each community is going to be really different, and that's the language we need to use right from the get-go. The other piece that I think doesn't fit is this is not a primary care model in rural communities. We don't pull out primary care as one part of our system. We provide overall care, right? So I think if anybody at any point talks about just primary care, I think they're not reflecting the reality in rural communities, unless you look at some novel definitions of primary care. So here's what FNHA is using. It's from the Alma Ata. And if you pull through some really neat things like, you know, it's universally acceptable to individuals and families in the community through their full participation at a cost the community and country can afford to maintain at every stage of their development in the spirit of self-reliance and self-determination. It's an integral part of both the country's health system, the overall social and economic development of the community. It's the first level of contact of individuals, the family, and community with the national health system, bringing healthcare as close as possible to where people live and work. And it's the first element, primary element, of a continuing healthcare process. All right, I'll buy in that we're talking about primary care model if that's your definition, but in the traditional definition that our health authorities use for primary care, I don't think we can talk about that in rural communities because we do kind of full spectrum care. Do you guys agree? Okay. So, recognizing that these are going to be different in all of our communities and that we're talking about full spectrum care, not just the typical definition of primary care, what does this look like in our communities? Let's pull apart some of these attributes. Oops, sorry, let me go back there. So the overall goal is patient-centered whole person care. Okay, those of you who work in rural communities, is that hard? It's generally not hard because most of the time we live in the community as well. So I know Mrs. Smith, not just from my 12-minute interaction with her on a Friday afternoon at 2, right? I know Mrs. Smith because she's in the community. I saw her at the Canada Day Parade, interacted with her daughter who works at the library. Her son works at the grocery store and had a nice conversation with them the other day. And I'm like, that's how we know most of our patients, right? And so grounding it, patient-centered, whole-person care, I don't have to often ask, you know, the school teacher, what about the stresses in her life? Because we live in the community, we all know they had a crisis there last week. So we're like 3 steps ahead in terms of grounding our care in the relationships. Those relationships are kind of supported and enhanced by our community connections. Now, patient-centered in the truest word, sure, we can all learn to do that better, right? But kind of in terms of starting point, we're way ahead in rural communities because of the relationships we have. And as a result, because we also live in the community, we can do a better job of wrapping those services around the patient. because we know where they live, we know what their issues are. And in terms of kind of the other elements, the socioeconomic, the geographic, the cultural components, again, we live that with people, so we know it better. So we can ground their care much better. I think we should see that center model as being grounded in local culture and community. So what does that mean? It might be First Nations culture, but it might also be ski hill culture, because you got a local ski hill. It might be in the culture of huge percentage of your workforce works in an open pit coal mine. Right? But you can ground the care in and around those cultural factors, whatever the culture is, because you know it so much better. Comprehensive care. Do you need to sell us in rural communities about this being part of our overall model? No, we deliver comprehensive care, right? In some of our communities, that means primary care and home care and emerge care. In some of our communities, it means surgical care, obstetrics care, right? Full spectrum care. But that has huge impact. So if I'm a GP in a rural community, and you talk about, say, access or some of the other pieces, if you're not recognizing that I'm part of comprehensive care provision, right, and that I do, shifts in emerge, or I do home care, or I do deliveries, then when we start to talk about some of the other pieces like access, you need to know that I can't be in my office 9 to 5, Monday to Friday every week if I'm also doing anesthesia in the local OR, or I'm also doing deliveries, or I'm doing an emerge shift. And that needs to be built into the recognition of the system. And that's where we know about teamwork, because I couldn't be in my office on Tuesday, so my colleague, whether it's a nurse or an NP or another doc, covers, right? And doesn't kind of just cover, but is truly part of the team that's providing care to this community. And for the most part in rural communities, depending on how we're set up, we generally provide care to the community, right? In some rural communities, we don't even have individual panels. There's just 3 or 4 or 5 docs that collectively, with other partners, other team members, take care of the community, right? And this idea of having panels doesn't even exist. In other small rural communities, people kind of do have panels, but it's much more flexible because they need to be cross-covering for each other when they're doing other services. So we need to be really flexible about that. So you can't even talk about comprehensive care unless you're reflecting the team parts of it. But I'll offer that in rural communities, we're in the best position to take a really 2017 novel approach to team-based care. That really gets rid of this idea that one doc has a bunch of patients. And it really is a team, a community team of providers that looks after a population. So it really is, within our clinic maybe, within your health center, within a geographic area, you're really grounding it in team-based care. And yes, we have to work at some of the details of that in terms of, where they chart and how they share the care plans and all of that. But when you're in small communities, that isn't so hard, right? So I think we shouldn't get stuck or hung up on figuring out those details and just start with where we're at and moving little steps forward. I often give this example. Friday evening, young 27-year-old, otherwise healthy male, right, comes into emerge to be seen because he's been busy working maybe in the local coal mine. Comes into emerge with respiratory symptoms. And really, if you look back in this record, he hasn't been seen for 4 years. He's healthy, and he probably won't be seen for another 5 years. He just happens to have respiratory tract symptoms, so he comes into emerge. And so he gets seen. In small communities, people have who does emerge care in small communities? It's the local GPs, right? And so in a lot of small communities, you have like a 1 in 4 or 1 in 5 or 1 in 8 chance of seeing your own GP in emerge, at night. That's phenomenal. We should be screaming that loud and clear to our people talking about access, right? But let's say by chance he didn't get to see his own GP. He sees one of the other 7 or 6 GPs that night in emerge. And he gets managed. And he needs follow-up. So the next Monday or Tuesday, he comes into the office for follow-up. Appropriate, right? So who should he see? He's not someone who uses the system very often. Should he see the doctor who's listed on his chart as his MRP? Or actually, maybe he should, depending. But equally, if he doesn't get seen very much, he doesn't have any other high needs, the MOA who knows him from the community knows that this is really just about follow-up about this. Could he not be booked in with the GP who he saw that night in emerge? Would that actually be better continuity of care for that isolated kind of episode of care? It might be. And I'm not saying there's right or wrong, but we probably need that kind of flexibility in our system with this idea of MRP. I'll give you another example. Mr. Jones, 78-year-old guy, some chronic, health issues, and he comes in with a nasty leg ulcer. When I worked for years in Pemberton, we had this phenomenal nurse that worked with us. Jill's going to talk about that a little later. Her name was Lynn, and she was an amazing CDM nurse and lots of things. She's, in the later stages of her career, she's done it and seen it all. So she's awesome with ulcers. Why would I be the MRP for that piece of his care? She would do the care regularly, would, connect and make sure it's documented, et cetera. But in terms of kind of episodes of healthcare, she should be the MRP for that. I think we need to be really flexible. If we're talking about forward-thinking team-based care, be really flexible and forward-thinking about what this MRP, most responsible, used to be physician, now it's provider. We probably need to be really even more forward-thinking about that. And I'll offer you the other thought, and that is that our young docs coming through, they don't want it. They do not want to do what a lot of us have done. They don't want to take on a group of patients on their own shoulders. They will absolutely join a team of people providing care, right? And where are they doing that? Right now, they're doing that in sports medicine clinics and other places because that's where they're seeing the best team-based care. They're not actually doing it so much in primary care because a lot of us are still stuck with the idea that I have to take on 800, 1,200, 1,600 patients. The new docs don't want to do that, but they will join a team if we can share with them and show them that you can be a number of docs and an MP and an RN and whoever social worker that will take care of a population of patients. So that's the other big impetus, I think, is for recruitment of our future colleagues. We need to broaden our thinking around team-based care. Okay, there's another attribute, commitment. I really think this little picture up here that shows one FP and one patient, I think that's flawed. I think that actually that little icon goes against our team-based care icon or idea, right? It's been quoted as a reliable relationship or attachment to a primary care provider. I think we need to be bigger thinking than that. I think actually from our providers, what's the commitment we're asking? I think you're actually asking for a commitment to the community, the health and the wellness of the community. Make that commitment, and the rest of the stuff will follow from that. And make a commitment to the team of people that's providing that health care. So who is that? That's not just docs and nurses, right, and NPs. It might be elders, might be way more wellness people, mental health providers. We need to broaden what we're thinking of in terms of health care and wellness care and really make sure our team reflects that. And it's going to be different in all of our communities. Coordination of care. So this is one of the 12 attributes. Do you have an issue coordinating the care in your communities? In your communities? Generally not, right? We're small enough. We're operating only out of a couple places. We know Sarah, the mental health counselor, and so if I have a patient that has a mental health issue, I just write a note or pick up the phone to call Sarah. Or frankly, in our really small communities, I walk down the hall and I talk to Sarah. And in our really small communities, it might even be that I know Sarah was at the schoolyard dropping her kid off this morning, and so I know she's going to be late for work. That's the level of detail we know some of our colleagues in our communities, right? So we don't have an issue with coordinating care in our communities. Where's our issue? It's once they leave our community. So now if you want to talk about our attributes and an integrated system of care, you can't just talk about your geographic health authority. Now we need to be having conversations with PHSA because that's who controls patient transport, right? And definitely with FNHA because that's who also provides the services to huge numbers of our rural population. So that's really different than the coordination of care as it was originally described in the diagram. Contact. Do you think most of your rural patients know how and where to best seek access out of ours? Sure they do, most of them do, right? But it's going to be different everywhere. In lots of rural communities, where's the only place you can see a doc beyond Monday to Friday, 9 to 6? In Emerge, right? Is that wrong? Well, some people in the system would say, that's not right. You shouldn't have CTAS 4s and 5s coming into Emerge. That's wrong. Well, no, it's not in our small communities, lots of them, because that's the only place the doc is. And it doesn't make sense to set up a whole second parallel system for accessing care, right? But then when you analyze our data, you need to take that into consideration, right? Lots of our rural communities, we don't have an ambulatory clinic, right? So if we want to do IV antibiotics on weekends or evenings, where does that happen? In Emerge. But then that's going to affect the data in our Emerge stats, right? And I often give the description of Powell River. A couple years ago, a year ago, there was this whole thing of their readmission data, readmission rates. So what's readmission? When you're discharged from a hospital and within 24 hours you're readmitted, right? So VCH looked at their data and said, hey, there's this failed discharge thing happening in Powell River. Well, what was it? When they really drilled down, it's that patients were being discharged from a Vancouver hospital and being readmitted within 24 hours to their home hospital, Powell River. Well, doesn't that make sense? That's actually good patient care, right? As soon as you can, get them out of the big city hospitals and send them home to their local hospital. But until somebody actually drilled down on that data and realized, oh, that's not failed discharge, that's actually good community care. So again, we need to be in the conversations around evaluation and stats analysis to say what's real in our rural communities compared to bigger urban systems. It's going to look different in each rural community. We think that this is about an ecosystem. And our rural communities are the best examples of some of those ecosystems, right? It takes a village to raise a child. It takes a village to run a rural healthcare system. We've all had this experience. Second doc, not on call, gets called to an emerge in the middle of the night. There's something nasty, and the neighbor comes in to take and look after their kids. And, Joe, the other neighbor, comes and helps deliver food, or like all those examples. We all have stories like that, right? It really is a little ecosystem. And so when we're looking at how to make this system work well, we need to look at the whole system, right? You lose a doc from a rural community. Community panics. What is sometimes the system says, okay, let's recruit another doc. Maybe we actually need to look at the whole system and say, what do we really need? What services do we need? Is it best to replace that with another doc? Or are there other team members or other elements of the whole system we can look at and learn from and do better with? If we support the whole system, then we build more security and continuity for patients. You announce in any rural community that Dr. X is leaving. Like in some communities, that sends an absolute panic through the community. But if the community knows that the rest of the team will still be there to look after them, right? As opposed to, Dr. X and his 1,200 patients then no longer have a doc. That's not how it works in most rural communities, right? The other providers kind of pick up the pieces and cover the load until they get other recruitment or other measures in place. That's the kind of patient medical home we want to promote. And so if we promote continuity of care for patients by looking at the whole ecosystem, we then build a more sustainable system, right? And we then diminish some of the fragility that exists in our rural systems. Because they're fragile little systems that hinge on not a lot of people. So we need to support the whole system so that when we lose one individual, the whole system doesn't fall apart. Do we need any more examples of that in BC, where we lose one or two docs out of a community and the community little healthcare system falls apart? No, we should be learning from that and fixing that. So here's the piece. What do we need to do our job better? We do a lot of things really well in rural communities, but what do we need? Well, there's a few things we need. We need systems that talk to each other. We need systems not only in our little communities, but then to the outside world. I can provide really good care for that mom and newborn who've just come back from a complicated delivery in the city, and they're back, just a couple days after delivery, and they're back in my little town. I can provide good care for them because I'm used to kind of managing that if I have the information. And if I don't have the information, I can't. So those are the types of things we need to be asking for in terms of structural enablers. It's good communication systems. We need leadership that is local, right? And resources that are local. It's no good saying you're going to give me, a podiatry nurse for a 0.2 in our community. Like, that doesn't work. That's not sustainable. No nurse is going to fill that position. You need to have more of a generalist, nurse that can do, 0.2 of her job might be podiatry care, but another part of it is other pieces. So we build, a full-time line or role out of it. And so then we need to collaborate, but not just with our regional health authority, also with FNHA and also with PHSA. And the whole CSC structure, didn't take that into account whatsoever. PHSA is not at the table, and FNHA is at some of the tables, but not all of them, and we need that. So what's going to work in your community? And all I would offer you from these kind of thoughts, and I should say these thoughts have been from a number of conversations across the province in the last year or two, is it's about grounding it about what your community needs. And stand strong in that, right? I know that's what you think. I know that's what worked in the next community over. But in this community, here's our reality. In this community, this is what we need. And we need to stand up and have those conversations.